Good afternoon. We're going to discuss the upper respiratory infections, and it will include otitis media and otitis externa. Before we go into the medications, let's talk briefly about what you know from pathophysiology about this disease process. External otitis is an acute infection of the ear canal. It's outside, it's external. Typically, it's caused by viruses, which are the most common, and these are adenovirus, respiratory syncytial virus, coronavirus, and enterovirus. But in addition, it's also caused by bacteria. Pseudomonas are the most common in pediatric population because remember, the immune system is not well developed. The symptoms could include pain discharge and hearing loss if the ear canal has swollen. Manipulation of the auricle causes pain, and diagnosis is basically by inspection, pulling the tragus and ear canal. And the treatment is basically, as you would see, debridement and topical drugs, including antibiotic, corticosteroids, as well as acetic acid and a combination of those. Children most of the time get acute otitis externa if they get flu-like symptoms or if they get 6 to 8 colds a year. Very, very common in daycare. Children that assist, that basically visit daycares. The adults average is 2.5 upper respiratory infections per year. External otitis may manifest as a localized furuncle or as a diffuse infection of the entire canal. It could be generalized or it could be localized acute external otitis. This condition is often called, as you know, swimmer ears. The combination of water in the ear canal and the use of cotton swabs is one of the major risk factors. So do not clean your ears with the swabs. You should only clean the outside, not the inside of the canal. Malignant external otitis is also common in mostly in pediatric population, and this is due by severe Pseudomonas osteomyelitis of the temporal bones. It's also present besides pediatric population in diabetic patients as well as immunocompromised patients. It could last from 7 to 9 days. It's very self-limited if it's um, related to viral diseases, which is the most common. Uh, Etiology, as previously stated, most likely viral Pseudomonas in immunocompromised patients and diabetic patients, as well as pediatric patients. Fungal otitis in the same population. There are many predisposing conditions for acute otitis externa, and that includes allergies. If the patient has any type of eczema, if the patient has seborrheic dermatitis or any irritants such as hair dye or hairspray, or any injury to the canal, or when you clean your ears with cotton swabs or any foreign object present in the canal. So any attempts to clean the ear canal with cotton swabs can cause micro abrasions of the skin that is very delicate in the ear canal, which act as portal of entry of bacteria and may push debris as well as and cerumen deeper into the canal. So these accumulated substances tend to trap water, resulting in skin maceration that sets a stage for bacterial infection. As you could see, patients could have significant runny nose and cough on days 1 to 4, predicting for viral origin. Patients mainly present with pain and drainage. Sometimes a foul smelling discharge and hearing loss occur if the canal becomes swollen or if it's filled with purulent debris. Tenderness is associated with traction of the pinna or ear canal and also pressure over the tragus. Otoscopic examination is painful and it's difficult to conduct. It shows that if you could do it, that the ear canal is red, is swollen, and also you could see the presence of moist and purulent debris. So patients could have nasal congestion, rhinorrhea, malaise, scratchy or sore throat before getting acute otitis externa or even media. The nasal discharge typically starts clear and they could progress into yellow or greenish if it's related to bacterial infection. Patients have generalized symptoms of flu-like symptoms. Um, Adult usually don't have fever, but the children may have a low-grade fever. Diagnosis is based on inspection, and when the discharge is copious, the external otitis can be difficult to differentiate from acute, purulent otitis media, and also when the tympanic membrane is perforated, is really difficult to distinguish. Pain with pulling of the pinna and indicates that external otitis is present. And you would see that treatment is related to basically the debridement, topical acetic acid or corticosteroids, and also sometimes topical antibiotic. So basically, the treatment is related to symptomatic relief with fluids, antipyretics, nasal bulb suctioning in infants when it's associated with nasal congestion and flu-like symptoms, decongestants in older children and adults, because remember it does contain most of them phenylephrine, which is a catecholamine. For acute otitis externa, it mainly viral, which is the most common disease process. No antibiotic treatment is necessary unless there is a bacterial infection superimposed. So for decongestants, you could use systemic sympathomimetics, which are pseudoephedrine or phenylephrine. You have the ephedrine and also the phenylephrine. Remember that these catecholamines could produce hypertension, tachycardia, nervousness, and jittering, and also is potential for abuse. Main mechanism of action is vasoconstriction of the capillary vessels, and this is the reason why it decreases congestion. But look at the side effects that I just mentioned. It's basically a catecholamine, so it produces anxiety, restlessness, irritability, hypertension, and tachycardia. So you should avoid these products in adult and also children that have any type of cardiac arrhythmias as well as hypertension. In addition to the symptomatic relief, that you could use cough suppressants when it's associated with congestion and sputum production and flu-like symptoms. And these are the you could use guaifenesin, you could use dextromethorphan, and also as well associated with codeine if the cough is paroxysmal and does not allow the patient to sleep properly. So never suppress the cough because this is a reflex, but if it's up to the point that avoids the patient having a night sleep or good rest to recover, then you should use cough suppressants. But mainly try to use mucolytics, which is guaifenesin. So this guaifenesin, which is robitussin and mucinex, stimulates respiratory tract secretions and decreases viscosity of the respiratory secretions. It's highly used for any type of upper respiratory congestion. You could use it for lower respiratory congestions as well, as we discussed in COPD, chronic bronchitis, as well as pneumonia. So try to educate the patient on the proper use of decongestants. Remember that it does have catecholamine involved. Avoid the use in children. In your book says less than 4 years of age, but it's mainly less than 5 years of age. Elderly or patients with cardiovascular diseases, as well as any pediatric patient that has cardiac arrhythmias and any type of hypertension, should avoid that because it would produce unresolved or uncontrolled hypertension up to emergencies and urgencies. Remember that upper respiratory infections are self-limited, and the majority tend to be gone in 7 to 10 days. So try to encourage the patient to wait and basically do symptomatic relief before trying any type of antibiotic, because antibiotics are basically for bacterial superimposed infection. So for acute otitis externa, before we go into sinusitis, if you suspect any possibilities of having severe external otitis associated with bacterial infection or even cellulitis. What you could use is as antibiotic, you could use neomycin with polymyxin. You could use ciprofloxacin or ofloxacin. But remember, these are fluoroquinolones, so try to avoid ciprofloxacin and ofloxacin on pediatric population because of the rupture of the tendons. What else can you use? You could use sulfa-based ear drops. But again, if you have a patient with an allergic reaction to sulfa, you should also avoid that. So neomycin with polymyxin is enough if you're suspecting a bacterial infection. Of course, trying to avoid the triggers or the risk factors, and you could also use trying to alter the pH of the canal with 2% acetic acid, and that relieved the inflammation, as well as you could use the topical hydrocortisone. So let's talk briefly about sinusitis. And sinusitis, as you remember in pathophysiology, is an inflammation of the paranasal sinuses. Again, the same as otitis externa and even media is mostly associated with viral infections. So even though here we're going to discuss about bacterial infection, the most common cause of any upper respiratory infection is viral. Same viruses as the Otitis externa. It could include adenovirus, influenza virus, rhinoviruses, etc. In addition, could be bacterial or fungal infection. It also could be allergic reaction. So any patient that has asthma or allergic rhinitis could get into sinusitis. So symptoms mainly are nasal obstruction and congestion, purulent rhinorrhea or discharge, facial pain or pressure, and sometimes malaise, headache, and fever could be present. Pathogens that are bacteria are strep pneumonia, Moraxella catarrhalis, and Haemophilus influenza, as we discussed in the lower respiratory infections as well in pneumonia. So if you see that a patient you have treated symptomatically suspecting that is self-limited due to viral infection and the patient is not improving for at least 10 days, you should suspect bacterial infection. So sinusitis, remember that it may be classified as acute if it has completely resolved in less than 30 days, subacute if completely resolved in 30 to 90 days, or chronic if it's beyond that. The etiology, if you are thinking an immunocompetent patient, then rhinoviruses, influenza, and parainfluenza, as well as adenovirus, as we discussed. In addition, if any sign or symptom makes the patient suspicious for bacterial infection, remember that the most common are streptococci, pneumonia, Haemophilus influenza, Moraxella catarrhalis, and even staphylococci. Occasionally, a periapical dental abscess. So if the patient has any type of dental abscess, could spread to the sinuses. So any hospital-acquired acute infection should be suspicious of bacterial infection. Any abscess in the dental area should be suspicious for bacterial infection. There is also allergic sinusitis that is very commonly present in patients that have asthma or allergic rhinitis or nasal polyps when they're present. So if it's so, besides treating the patient with bacterial infection, try to put the patient on any type of antifungal, thinking about possible aspergillus. Common risk factors for sinusitis, again, allergic rhinitis, nasal polyp, having nasogastric or nasotracheal tubes, any immunocompromised host, diabetes, HIV infection, any prolonged ICU state, severe burns, cystic fibrosis patient, or any patient that has any type of ciliary or nasal hairs dyskinesia. Remember, the pathophysiology is the patient normally has an upper respiratory infection prior that develops swelling of the nasal mucous membrane, and that results in a negative pressure in the sinuses, producing pain, transudate that develops, or potentially will make the sinuses fill up with mucus, and of course, superimposed bacterial infection, and even cellulitis. Patients could develop. But remember, again, since it's priorly actually what happens before is most of the time is an upper respiratory infection. You must think about the possibility of viral infections before you think about bacterial infections. So give a trial and wait, or waiting watch period before you attempt any type of bacterial infection. Symptoms are exactly the same for both acute or chronic. The patients would have, as I said, rhinorrhea, pressure and pain in the face, nasal congestion, lithosis. So patients would have bad breath, productive cough, especially at night because they tend to have postnasal drip. In addition, if you press on the sinuses, since there's swelling and erythematose inside, it hurts. Depending on where the sinusitis is located, if it's frontal, patient would have frontal headache. If it's ethmoid sinusitis, they would have pain behind the eyes, and tearing as well. And the diagnosis basically is by clinical evaluation. You would be able to assess this in health assessment by illumination of the sinuses. You would see that they're opaque instead of translucent. If the patient will lean forward or cough or produce any pressure in the sinuses, it hurts. In addition, of course, besides clinical evaluation and cultures of the secretions, you could do a CT scan of the sinuses to be able to diagnose these. So treatment-wise, basically try to promote drainage with vaporizers or steam, and you could use also topical vasoconstrictors and of course fluid. But as antibiotic of choice for sinusitis, the first initial choice antibiotic would be, and your first line would be amoxicillin. You have the dosages there. If the patient fails to improve with amoxicillin, then you could use amoxicillin clavulanate, which is augmenting. In addition, if the patient is allergic to penicillin and there is no type 1 hypersensitivity reaction, which is anaphylaxis, you could use any type of second and third generation cephalosporin, which is ceftiofur, cefuroxime, and cefpodoxime. But if the patient has type 1 hypersensitivity reaction, you could use the macrolide antibiotic, which are your azithromycin and clarithromycin. In addition, you could use trimethoprim sulfamethoxazole, which is Bactrim. Now, before we go to here, let me bring up an algorithm that you have on your book. That is very useful for sinusitis and any type of disease process that produces either allergic rhinitis, common cold, or any type of purely nasal discharge. So if the symptoms persist and not improve more than 10 days, of course, you're not going to think anymore about viral infections. Or if the severe symptoms persist for more than 3 or 4 days, there is double sickening or worsening of the symptoms after 3 to 4 days. So that means that, okay, patient is on symptomatic relief, but the patient has high fever, the patient has malaise, that has purulent discharge that is not improving after 3 to 4 days, or they're getting worse after 3 to 4 days, or there's a mild improvement but the symptoms persist after 10 days, then patient is basically most likely really having a bacterial infection, and you must consider antibiotic. So is this patient at risk for resistant, and I should change, and I was in viral symptomatic relief and I have to start antibiotic, or I was already thinking that the patient had a bacterial infection and most likely the amoxicillin did not do enough since it's the first line, and I would have to step higher up to amoxicillin clavulanate, for example. Or is this patient having any type of comorbidity, or this patient already used antibiotic in the past month? Is this patient immunocompromised, or this patient was hospitalized in the past 5 days? So I would have to improve my treatment level. So if the answer is no, then to the above, either the patient is getting better and you continue viral treatment, but if the patient is not getting better, okay, then you should start antibiotic treatment if you already did not do so. So if the patient is on amoxicillin or amoxicillin clavulanate and there is an improvement, continue the treatment for 5 to 7 days and even 10 days if it's in children. But if there is worsening or no improvement of the symptoms, then you should initiate the second line of treatment. If you were already on amoxicillin, then go to amoxicillin clavulanate. If you were already in amoxicillin clavulanate, then increase the dose of amoxicillin clavulanate. Or maybe you should add a cephalosporin. Or maybe you should switch to a fluoroquinolone, of course, if the patient is an adult, because the children should not have any type of fluoroquinolone. If there is improvement after you did this, then continue the treatment for 7 to 10 days, or 10 days if it's in children. If there is no improvement, on the contrary, there's worsening of improvement of the symptoms after 3 days after you change from amoxicillin to amoxicillin clavulanate, or if you were in amoxicillin clavulanate already, increasing the dose, or if you already added a cephalosporin and the patient is not improving, or if you were adding a cephalosporin and the patient is not improving and you switch to a fluoroquinolone because the patient is an adult, then you should refer the patient to an ENT physician. So, in other words, you were an amoxicillin, patient is not getting better, go to the second step, amoxicillin clavulanate. If you already started from the beginning an amoxicillin clavulanate, increase the dose. So to the high dose level of amoxicillin clavulanate. If this is not improving, then go ahead and switch to a cephalosporin or a fluoroquinolone if the patient is an adult. Another way to represent this, sorry, this is otitis. Yeah, again, this is otitis. But more or less, if you look at otitis, it's very, very similar. Look here. The patient is on amoxicillin. The patient is not getting better. Go to amoxicillin clavulanate. Okay? An alternative of allergy, the same for sinusitis, if you had no type 1 hypersensitivity reaction, it's okay to use cephalosporin second generation. If not, if you're type 1 hypersensitivity reaction, you could do azithromycin or clarithromycin. But look here, it's very, very, very similar to sinusitis, even though this is otitis media. The patient failure to treatment after 3 days, okay, or after initial management of observation thinking that it is a viral infection, then the alternative is to go ahead and jump into amoxicillin clavulanate high dose. If you were already in amoxicillin clavulanate, switch to a higher dose, or you could start either ceftiofur, cefuroxime, cefpodoxime, or ceftriaxone for 3 days. Okay. Otherwise, then you should refer to an ENT physician. Or if the patient, for example, is diabetic, or if the patient, you're thinking that there's a possibility of Pseudomonas or any type of immunosuppressed disorder, then you should start as well with clindamycin. So, the goal of treatment is basically absence of infection and resolution of all the symptoms. So again, let's review. A first-line treatment for sinusitis is amoxicillin, and in addition, you could use Bactrim DS. For adults, you could use fluoroquinolones. If the patient is allergic to penicillin, if it's a non-type 1, ceftiofur, cefuroxime, or cefpodoxime, why not ceftriaxone? There's no contraindication to use that at all. It's just that there's no need when you could use a second generation cephalosporin. If the patient is not getting better, of course, you could go straight to a third generation cephalosporin. If the patient has a type 1 hypersensitivity reaction, then clarithromycin or azithromycin. Now, if the patient is in a daycare or have used antibiotic for the past 90 days, I would not start on amoxicillin alone. I would start right away in amoxicillin clavulanate high dose or ceftiofur, cefuroxime, or cefodoxime. Okay, if this is an adult with child in daycare or the adult itself going to a daycare, because now we do have elderly care, we should go ahead and start amoxicillin high dose or amoxicillin clavulanate. There's no reason why not to do that. Now, the second line antibiotic for sinusitis, you could start the patient on amoxicillin for 3 to 5 days. If the symptoms are improving, continue 7 days more, and total 10 to 14 days. Basically, the algorithm says 10 days if it's the pediatric population. But if the patient is not improving, okay, you wear an amoxicillin, go ahead and start amoxicillin clavulanate or cefuroxime, ceftiofur, cefodoxime. If this is an adult, then fluoroquinolone, never for the children. So again, if you're suspecting bacterial infection, go and start the patient on amoxicillin. If the patient is not improving after 3 to 5 days, switch to amoxicillin clavulanate high dose, or you could use cefuroxime, ceftiofur, or cefodoxime, or why not ceftriaxone. And if this is an adult, then you could do fluoroquinolone, but you could do the above as well. Now, if the patient is allergic, then of course you could do azithromycin, and you can even add clindamycin to it if the patient is diabetic or immunosuppressed. So don't forget the symptomatic relief, nasal spray or drops with saline that liquefies secretions. Try to decrease crusting near the sinus ostia. Topical decongestion that decreases tissue edema and enhances drainage of secretions, as well as corticosteroids. Now let's talk about acute otitis media. And it's basically, again, the most common cause is a viral infection, but it could also be associated with bacterial infection of the middle ear, usually associated with, again, upper respiratory infection. And that includes symptomatic otalgia and fever, nausea, vomiting, and diarrhea. Remember that fever, even though it could be present in pediatric population in acute otitis externa, is not a common finding. In addition, patients could have vomiting, could have diarrhea, especially in the pediatric population. Although acute otitis media can occur at any age, it is very, very common between the ages of 3 months and 3 years in pediatric patients. At this age, remember that the Eustachian tube is structurally and functionally immature, and the angle of the Eustachian tube is more horizontal. So the problem is that the angle being horizontal and the cartilage open mechanism for superimposed infection, and is less efficient for clearance of the secretions. So the etiology of acute otitis media is viral until proven otherwise. But it could be, of course, complicated with bacterial infection. In neonates, besides the bacterial infection that we have mentioned, you have to think about possible gram-negative bacterial bacilli or E. coli or staph. Okay, if this is an older children, less than 14 years of age, it's the same as the adult, which is strep pneumonia, Moraxella catarrhalis, and Haemophilus influenza. Now, the good thing is that we do have vaccinations against strep pneumonia and Haemophilus influenza. The risk factors, very, very similar, but here we have a very strong risk factor that is not present in the other open respiratory infections, and this is smoking. So smoking in the household is a significant risk factor for acute otitis media. And it doesn't matter if you smoke outside, if you carry the nicotine inside and you hold your baby, it's exactly the same. And of course, attending daycare centers that we already discussed. So diagnosis requires a history of acute onset of symptoms, the presence of middle ear effusion, signs and symptoms of middle ear inflammation. So erythema is non-specific. You could have erythema and not have acute otitis media, but you must have these three, and these are important to know. In addition, patients could have bullous meningitis, which basically is the major inflammatory process. So complications besides that, it could even go to mastoiditis and spread, even causing abscesses, subdural empyema, and even meningitis. So it's very important to recognize it and treat it properly. So the goal of treatment is basically to clear infections from the middle ear and try to do symptomatic relief first before you think about possible empiric antibiotic. So the guideline of acute otitis media in children applies very beautifully to adults as well. So initial observation without antibiotics for 48 to 72 hours is very important to remember. So try to do watchful waiting first for 72 hours before you start antibiotic treatment. So 3 days to 5 days. So if treating acute otitis media with antibiotic, so let's see what we have on the guideline. Give me a second. Right here. So you have no, I'm sorry, this is not related to, I'm sorry, I opened the wrong algorithm. I apologize. So the guideline for acute otitis media that I had it over here, yes. Okay, so is the temperature more or equal than 39 or the patient has severe otalgia? If the answer is no, the patient has no high fever, no severe otalgia, it's okay to start only with amoxicillin. But if your answer is yes, then instead of starting with amoxicillin, if the patient has high-grade fever or severe earache, then do not bother to do only amoxicillin. Do amoxicillin clavulanate, high dose. So a diagnosis for patients being treated initially with antibacterial infection. So if you were having these symptoms, go straight to amoxicillin clavulanate. If you do not have these symptoms, then it's okay to do only amoxicillin. If you're allergic to penicillin and is a non-type 1, it's okay to do second generation cephalosporin. If it's a type 1 hypersensitivity reaction such as anaphylaxis, then azithromycin or clarithromycin. So if the answer is yes to this, instead of amoxicillin, you're going to do amoxicillin clavulanate. And if you're allergic and it's a non-type 1, you could do ceftriaxone. Or if you're allergic to penicillin and it's a type 1, you could do clindamycin, for example. Now, clinically, the patient failed at 48 to 72 hours after initial management with observation. So if the patient did not have these symptoms, okay, and the patient was treated by watchful waiting, and the patient failed after 72 hours, then if you were not in any antibiotic, start amoxicillin, and it's the same pathway. If the patient, after watchful waiting, has 39-degree fever or severe otalgia, it's the same treatment, amoxicillin clavulanate, and the same options, ceftriaxone or clindamycin. Now, the patient was already on antibiotic and failed 72 hours after, then amoxicillin clavulanate, and if it's not a type 1, ceftriaxone. Okay? And if it's a type 1, clindamycin. But if the patient then after being on antibacterial infections continue with 39-degree fever and severe otalgia, then go straight to ceftriaxone and or tympanocentesis or clindamycin. So again, patient, you thought that it was a viral infection. The same applies for sinusitis. Okay, so if the patient, you thought, okay, let's do watchful waiting because the patient has minimal symptoms, low degree fever, it does not have major pressure on the sinuses or severe otalgia, it does not have rupture of the tympanic membrane and drainage purulent, or if it's sinusitis, no purulent discharge to the nose, and you decide, okay, let's do watchful waiting, and the patient is improving, keep it like that. If the patient is not improving after 72 hours and the patient does not have high degree fever or severe sinus pain or drainage or otalgia, then does not have that, you would start amoxicillin. And if the patient is allergic to penicillin, non-type 1, you could do cephalosporin. If it's a type 1, azithromycin or clarithromycin. But if the patient is having those symptoms, instead of starting amoxicillin, you could do amoxicillin clavulanate. And if the patient is allergic to penicillin, non-type 1 ceftriaxone, type 1 clindamycin. Now, let's imagine that from the beginning, okay, you never decided to do watchful waiting and you never thought about viral infection, which is the correct way. But the patient, even though you started the patient on antibiotic, the patient never had high fever or severe otalgia or severe sinus pain or drainage. So what you should do is you should do amoxicillin. And if the patient is allergic, non-type 1, cephalosporin. If it's a type 1, azithromycin or clarithromycin. But if you from the beginning decided to start the patient on antibiotic and even the patient failed not to improve after 72 hours on amoxicillin, then you switch to amoxicillin clavulanate high dose. If the patient is allergic to penicillin, non-type 1 ceftriaxone, type 1 clindamycin. But if you never decided to do watchful waiting because the patient from the beginning had high degree fever, severe otalgia, nasal pressure, and discharge, you do not start the patient on amoxicillin. You go straight to amoxicillin clavulanate. And if the patient is allergic to penicillin, ceftriaxone. And if the patient is if it is a type 1, then clindamycin or tympanocentesis. I hope that helps for both, for sinusitis and otitis. Okay, so the same applies on the upcoming PowerPoints. So basically, if the patient is less than 6 months, you would start the patient on antibacterial infection. If it's an uncertain diagnosis as well, 6 months to 2 years of age, antibacterial therapy. If you're certain, if you're uncertain, you could do antibacterial only severe illnesses. If it's more than 2 years, if you're certain that it's a bacterial diagnosis, then go ahead and start. Otherwise, please do observation as an option. So again, amoxicillin is the first choice. And as you could see, the upcoming slides are related to the explanation of the guideline. So remember, risk factors that must be considered for bacterial infections are daycare, recent receiving antibiotic treatment, age younger than 2 years of age, and again, this is the explanation of the guideline. Another type of antibiotic that you could use in a non-high degree illness or high fever or high otalgia, if you're allergic to penicillin and is a type 1, is sulfa, which is Bactrim. Okay, here's the explanation of the guideline that we already discussed. Low risk patients more than 2 years of age 6 months to 2 years with uncertain diagnosis, temperature less than 39 degrees. So those are the patients that you must do watchful waiting first. Okay. Of course, pain relief with acetaminophen is a prefer. Okay. Then if it doesn't help, then you step up to NSAIDs, which is ibuprofen. You could do also topical analgesics with a combination of antipyrin, benzocaine, and glycerin. And of course, the tympanic membrane must be intact. So reconsider daycare attendance, breastfeeding for the first 6 months of life, and avoid bottle propping. So patients that are breastfed are less prone to have sinusitis and otitis, and the ones that are bottle fed are more prone to that. And of course, reduce exposure to tobacco smoke. Never allow the child to smoke next to the parents or anyone, or even being carried by anyone that smoke. Try to educate the patient on the proper use of medication. Complete the cycle of antibiotic if you suspect a bacterial infection, because you will basically promote resistance and pain control. Okay, so we'll leave it here, and on the next video we'll do drugs used to treat eye and ear disorders, and we'll also cover tuberculosis. Good morning. Today we're going to discuss the pharmacology and pharmacokinetics and dynamics of the disease process related to eye and ear. This will include not only the treatment for ophthalmic anti-infective, for example, in conjunctivitis and blepharitis, but also in addition, we're going to talk about the agents for the treatment of glaucoma, allergic conjunctivitis, any anti-inflammatory agents, lubricants for keratoconjunctivitis sicca or dry eye, diagnostic products that are used for disease processes, and in addition, seromenolytics for wax, analgesics, as well as otic anti-infective in the case of otitis. So when you went over the anti-infective agents, systemics, you discussed the definitions of bacteriostatic and bactericidal. And remember, the bactericidal is the agent that is able to kill a bacteria, and the bacteriostatic is the one that is able to retain the process of mitosis or generate or regeneration, but does not kill the bacteria. So remember that even though this is otic or ophthalmic, these medications do have a minimal systemic absorption, so you might encounter some side effects in the systemic circulation as well. You have to be very careful with hypersensitivity in the case, for example, if you're going to be using any type of sulfa containing products, because patients that are allergic to sulfa could not only have a hypersensitivity reaction type 1 related to skin rash, but up to the point of bronchospasm and even Steven Johnson. Local irritation is one of the other drugs reaction for these agents, otic and ophthalmic. Superinfection with prolonged use in the case that you used any type of steroids. Toxicity, not only ocular but also at the level of the kidney in relation to aminoglycosides, and also otic as well, because remember, aminoglycosides could produce ototoxicity. Fluoroquinolones, remember that it cannot be used in pediatric population because even though it is local, it could have some systemic absorption and could produce tendon rupture. In addition, it could crystallize and precipitate in the cornea. There's no drug interaction reported for bacitracin, tobramycin, azithromycin, etc. Sulfacetamide is incompatible with silver containing preparation, just in case you want to do a diagnostic study at the same time you're going to be using sulfacetamide, or for gonococcal conjunctivitis as well. So let's talk about some disease process and treatment related to it. Let's start with ophthalmia neonatorum, which is basically neonatal conjunctivitis. It's no more than a watery or purulent ocular drainage due to chemical irritant or a pathogenic organism in the case of gonococcal conjunctivitis, which is basically a bacterial conjunctivitis. Prevention with the anti-gonococcal topical treatment at birth is routine, is part of the protocol and screening. The etiology of ophthalmia neonatorum, again, the major causes in decreased orders are bacterial, chemical inflammation, and viral infection. So infections acquired from infected mother that has either chlamydia or gonorrhea through the passage of the birth canal can cause these bacterial causes of infection. It basically accounts for 40% of conjunctivitis in the neonates less than 4 weeks. The prevalence of maternal chlamydia infections ranges from 2 to 20%. Symptoms, because they overlap in manifestation and onset, uh, all the different causes of conjunctivitis, as again, as I said, bacterial, chemical, and even viral, is very difficult to distinguish clinically. So the conjunctiva is injected red with discharge, either watery if it's viral, for example, or purulent if it's bacterial related. Chemical conjunctivitis is secondary to topical prophylaxis, usually appears within 6 to 8 hours after instillation and disappears spontaneously. Chlamydia conjunctivitis usually occurs between the 5 or 14 days after birth, and it may range from mild conjunctivitis to minimal mucopurulent discharge to even severe edema. Gonococcal conjunctivitis is purulent and it does appear 2 to 5 days after birth, and even more if there is earlier premature rupture of membranes at the level of delivery, at the moment of delivery. Diagnosis basically is testing the conjunctiva of the neonate for these pathogens. So you do a culture and grand stain for gonorrhea. In the case of gonorrhea, you're going to be doing the Thayer-Martin medium. Or even you could do direct immunofluorescence or scraping with GM-SAT stain for chlamydia and even for viral. Treatment is the one that is posted in your slide. Requires the gonococcal conjunctivitis requires intramuscular third generation cephalosporin, which is ceftriaxone, to be able to spell out the bacterial infection. So neonates with conjunctivitis and non-maternal gonococcal infection or with gram-negative diplococci should be treated with ceftriaxone or cefotaxime. And again, it has to be systemic. Prevention, so the treatment is already mentioned, and the prevention is with erythromycin ointment within 1 hour of birth. In chlamydia, systemic therapy is the treatment of choice because at least half of affected neonates also have nasopharyngeal infection, and some developed chlamydia pneumonia. So it's very, very similar to the prevention, but instead of the ointment, you have to give systemic erythromycin. The bacterial conjunctivitis, in general, let's discuss before we go there the overview of all the conjunctivitis so you could understand better the different types of conjunctivitis. As we discussed in pathophysiology, conjunctivitis is an inflammation of the conjunctiva that typically results from infection, but it could also be allergic or it could also be related to irritation. So the symptoms are hyperemia, ocular discharge, and depending on the etiology, discomfort and itching. Is most commonly viral or bacterial and is contagious in nature. So, in addition, numerous allergens can cause allergic conjunctivitis, and this is the patient that most likely has an asthma or hino fever or nasal polyps as a past medical history or even family history, and now they come with the conjunctivitis. Of course, allergic conjunctivitis tends to be bilateral symmetric because it's a systemic problem, so it comes in both eyes. The difference with infectious conjunctivitis, either viral or bacterial, is that it starts with one eye and then spreads to the second eye. And the major difference between those two infectious processes, the discharge. So the discharge in the viral will be clear mucus, and in the bacterial will be purulent, yellow, greenish. So any source of inflammation causes lacrimation or discharge and diffuse conjunctival vascular dilation. Discharge may cause the eyes to cross overnight. Thick discharge may blur vision, and it could affect the visual acuity as well. Itching and watery tends to point more to allergic. Chemosis and photophobia, purulent discharge tends to be more for bacterial infection, and mucoid bilateral is viral. The diagnosis, as we discussed in pathophysiology, is more or less based on the clinical signs and symptoms, and you could do cultures as well, but that's rarely done. So in children 3 months to a year, most likely is related to staphylococci, streptococci, and Haemophilus influenza. Um, Staph aureus and Pseudomonas aeruginosa is most commonly in elderly population, and any single patient that has immunocompromised disorder, including diabetes and autoimmune disorders, HIV, etc. And we already discussed the treatment related to it. Now, sometimes patients do have any type of upper respiratory infection that complicates with conjunctivitis. The problem is that if you have nasopharyngitis or if you have sinusitis, um, when the patient, mostly the children, cleans the secretions with their hands and then pass the hands through the eye, patients could have complication with conjunctivitis. Otitis syndrome, the problem is that there's no external secretion, but all the upper sinuses and the Eustachian tube communicates, and also the lacrimal glands, so patients could have complication with conjunctivitis and otitis syndrome at the same time. So most of the time happens in children younger than age of 6 because of the Eustachian tube is more horizontal, has more communication to the sinuses and the lacrimal gland, and at the same time it's more difficult for clearance of secretions at that age. Haemophilus influenza is mostly the causative organism in the majority of these patients having conjunctivitis otitis syndrome and even conjunctivitis upper respiratory infection syndrome. And the treatment is exactly the same as otitis media, so it will be high dose amoxicillin or amoxicillin clavulanate. We already discussed the treatment for gonococcal conjunctivitis. So let's talk about blepharitis. And blepharitis is no more than an inflammation of the eyelid margin that may be acute or chronic. Symptoms and signs include itching and burning of the eyelid margin with redness and edema, and also crusting. The diagnosis is mostly by examination and the history. It could advance to the point of produce ulcers in the blepharos, which is no more than the eyelid margins, which are called like that. And the treatment is basically antibiotic. Etiology, it could be acute, it could be chronic, it could be related to, most of the time, staphylococci of the eyelid, and the lash follicles and meibonia glands are also involved. It could be viral related, it could be related to herpes simplex or varicella zoster. And in chronic, It could be also produced by lipids in the mammalian gland, such as chalazion. For patients that have seborrheic dermatitis or even rosacea, can produce this in the blepharos. So treatment is basically scrubbing the eyelashes with shampoo, and of course the shampoo has to be tear free and mostly baby shampoo. Applying erythromycin ophthalmic ointment is the treatment of choice. But you could use bacitracin, polymyxin B, or you could use gentamicin. And if you suspect this is a viral infection related to herpes simplex or zoster, you could treat it with acyclovir, fanciclovir, or valacyclovir. Now, another disease process that we also have discussed in pathophysiology is ordeolum stye or chalazion. Remember that chalazion and ordeolum are sudden onset localized swelling of the eyelid. Chalazion is caused by non-infectious meibomian gland occlusion, whereas the ordeolum is usually caused by staphylococci infection. Both conditions initially cause eyelid hyperemia, edema, swelling, and pain. With time, chalazion becomes small, non-tender nodule in the eyelid center, whereas the ordeolum remains painful and localized to an eyelid margin. Diagnosis is clinical, and basically the treatment will be hot compresses, um, steroids intralesional, and even ophthalmic antibiotic for the chalazion in this case. Both conditions tend to improve spontaneously, but sometimes chalazion needs incision and drainage. Viral conjunctivitis usually is caused by adenovirus, herpesvirus, and herpes zoster. The treatment we discussed that most of the time is acyclovir, valacyclovir, and valacyclovir, but you could use the ophthalmic antibiotic as well in case you want to avoid superimposed infection. You have to instruct the patient to prevent contamination because in the case of conjunctivitis is um, contagious. Instruct how to instill drops or ointment. In this case, if it's a pediatric patient, to the mother or a caretaker. Educate them on the adverse drug reactions, hand washing, non-sharing towels, throw away eye makeup that is even expired because expired makeup could produce blepharitis, could produce ordeolum, could produce chalazion, and also could produce conjunctivitis. Clear purulent discharge with wet cotton ball or washcloth could be eliminated. Now let's talk briefly about glaucoma. And if you recall, it's a group of eye disorders characterized by progressive optic nerve damage, in which an important part is a relative increase in intraocular pressure. Glaucoma is the second most common cause of blindness worldwide and the second most common cause of blindness in the United States. Leading population is Hispanics and African Americans for glaucoma. We have, if you remember, open angle glaucoma and closed angle glaucoma. And basically, if you recall, most of the aqueous humor is produced by the ciliary bodies and exits the eye at the angle formed by the junction of the iris and the cornea, which is called iridocorneal angle. It exits primarily via trabecular meshwork and at the Schlemm canal. And when there is any type of damage at this level or occlusion, the intraocular pressure gets elevated, and that plays a very important role in axonal damage because there is nerve compression, optic nerve compression at that level. One factor that may be the external measurement of intraocular pressure does not always reflect the truth. The cornea may be thinner than average, which leads to a higher intraocular pressure measurement, um, or thicker than average, which leads to lower intraocular pressure measurement inside the eye. So you have to take into account the thickness of the cornea when you are measuring intraocular pressure. So it has to be done in a very specialized facility or with an ophthalmologist. So remember that intraocular pressure is determined by the balance of the aqueous secretion and drainage. So anything that inhibits or obstructs the outflow or produces oversecretion of the aqueous humor, or even a combination of factors that blocks the trabecular meshwork could produce glaucoma. Signs and symptoms, if you recall, um, basically is eye pain, and it's basically due to nerve damage. Visual fields could be altered. Diagnosis is basically by clinical signs and symptoms, measurement of the intraocular pressure, which is usually more than 21 millimeters of mercury um, when the patient has glaucoma. Glaucoma should be suspected in any patient with either abnormal optic nerve when you look at the through the ophthalmoscope, elevated intraocular pressure, typical visual field defect, or any family history of glaucoma. And the treatment, it must be treated by an ophthalmologist. And the common anti-glaucoma agents are beta blockers, adrenergic agonists, myotics, carbonic anhydrase inhibitors, sympathomimetic, prostaglandin agonist. If you want to decrease intraocular pressure by using drugs or laser or incisional surgery, could be done as well. Patients with characteristic optic nerve and corresponding visual field changes are treated regardless of intraocular pressure measurement. So lower the intraocular pressure measurement is the only clinical proven treatment. Three methods are available: drugs, the one listed in your slide, laser surgery, and incisional surgery. The type of glaucoma determines the appropriate method. Drugs and most laser surgery, which is called trabeculoplasty, modifies the exiting aqueous secretion and drainage. Traditional incision surgeries that are called trabeculostomy or trabeculectomy or filtration procedures, they basically create a new drainage pathway between the anterior chamber and the subconjunctival space. Prophylactic intraocular lowering in patients with ocular hypertension delays the onset of glaucoma. However, because the rate of conversion from ocular hypertension to glaucoma in untreated people is low, the decision to treat prophylactically should be individualized based on the presence of risk factors. So, beta blockers basically vasodilate and opens the angle, as well as adrenergic agonists produce vasodilation. Myotics, by reducing the size of the pupillary, also allows the anterior chamber to drain properly. Carbonic anhydrase inhibitors, they are basically diuretics that decrease the amount of production of aqueous humor, as well as prostaglandin agonist or analogs that basically produce dilation and opening angle at the level of the canal, Schlemm canal. So they basically are absorbed and systemic levels reach enough to cause complications on patients that have chronic conditions. So you have to have that in mind. In addition, we could use, besides the treatment for glaucoma, we could use medications for example, allergic conjunctivitis. You could use mast cell stabilizers, which are your cromolyn sodium, chrolum, or iodosamide, aldomide. You could use antihistamines. In this case, your prototype will be antazoline vasocon, but there are many more, such as levocabastine or ketotifen, which is the Zaditor. They limit basically the hypersensitivity reaction and inhibit degranulation, and as well as they block histamine receptors. So going back again to glaucoma before we advance, the initial choice drug for glaucoma is either your beta blockers, such as timolol, or prostaglandin analogs, such as latanoprost or tafluprost. If those don't work, then you have the second choices, which are your either miotics or carbonic anhydrase inhibitors or sympathomimetics. In addition, you could do laser trabeculostomy or guard filtration procedure. So, in case of angle closure glaucoma, the treatment for acute would be your beta blockers again, timolol. You could use pilocarpine. In the acute, instead of using prostaglandin analogs, you could use oral Diamox, which is the carbonic anhydrase inhibitor, or acetozolamide, which is basically a systemic osmotic drug, followed by laser surgery or iridotomy. For chronic, you could do laser surgery and continue with the beta blockers. Okay. Now, you have to have in mind the possible hypersensitivity reaction that these drugs could have due to local or systemic absorption. Okay, remember that this could affect the soft contact, the lenses, produce blurred vision or eye discomfort, or even tearing. Or tearing, I'm sorry. These again are the medications that are used for any type of allergic conjunctivitis, which is also called vernal conjunctivitis, and those are the histamine blockers and the mast cell stabilizers. In addition, for pain, you could use the ophthalmic NSAIDs, which is no more than Voltaren or Suprofen or diclofenac or ketorolac, but in ophthalmic solution. You could also use corticosteroids. You could use any type of anti-inflammatory drug for this type of disease process. You know, when the patient is complaining of red eye, or which is the same as pink eye syndrome, or pain, no more than ocular pain. Remember that if the patient continues to have symptoms, you must refer the patient to an ophthalmologist. Might require corticosteroid therapy. Educate them about the adverse drug reactions, such as the tearing and discomfort, and also headache, or for example, if the patient is using any type of histamine blocker, in the case of nafoxylin, that could precipitate narrow angle glaucoma. So never give it to any patient that has this chronic condition already. steroids, besides all the side effects that remember that it could produce glaucoma, it could produce cataract as well, and even superimposed infection in the eye. So for vernal conjunctivitis, you should use ocular NSAIDs if the patient is complaining of pink eye or eye pain. Refer the patient to an ophthalmologist if you should prescribe corticosteroids, and the education about the side effects. If the patient is complaining of, for example, keratoconjunctivitis sicca, which is the dry eye syndrome, which is no more than the cornea that gets dry, and most likely because there's inadequate tear film. The symptoms is basically itching, burning, irritation, and photophobia, and diagnosis is clinical. You could do Schirmer test to be able to diagnose keratoconjunctivitis sicca, but it's not usually done. And the treatment is mostly medications that lubricate the eyes, and also sometimes unblocks the nasolacrimal opening. So you could use artificial tears. Basically, what they do is they balance the amount of lacrimal tears that are produced and maintain ocular tonicity and buffer. For red eye syndrome, which is no more than pink eye, it refers to a red appearance of the opened eye, reflecting dilation of the superficial ocular vessels. What happens is that it could be completely asymptomatic and chronic. It could be related to infection, to allergies, to inflammation, and also to elevated intraocular pressure. The etiology of infections could be conjunctivitis, it could be allergic from allergic conjunctivitis, it could be a corneal abrasion, it could be a foreign body, it could be any irritant or makeup. So basically for those who use ophthalmic vasoconstriction, it's basically for temporary relief of redness, but it tends to create a tolerance and addiction. They do constrict conjunctival blood vessels, but they could produce neuroangular glaucoma as chronic use, and of course hypersensitivity as well. So basically, as a transient stinging and burning that produce temporary blurred vision, but that could increase intraocular pressure and rebound congestion and redness again once the patient once passes 4 to 6 hours. So that's the reason why the patient tends to create tolerance and dependence on these medications. It has a lot of drug and drug interactions, and you could imagine that it's related to any type of catecholamine, because that's basically what they have. It's basically used for temporary relief of eye redness due to irritation or allergy. You could use tetrahydroxylene or oxymetazoline or nafazoline. Nafazoline is also used for the nose, and also phenylephrine, but all of them contain phenylephrine as a potent vasoconstrictor. It is not recommended for children, and avoid prolonged and excessive use, as I said, because it could produce hypertension, it could produce intraocular pressure, etc. Now, sometimes the patient comes in with eye pain due to a foreign body or corneal abrasion, and what's used for diagnostic test is topical fluorescein. It's basically used to detect any corneal epithelial defect or abrasion. It's basically an orangey yellow acid xanthine dye that produces a very intense green color in an alkaline solution. And basically it detects all the epithelial defects. You basically instill 1 to 2 drops in the cornea with sterile water. You used a Wood's lamp to detect a defect, and you remove the excess with sterile saline after you're done with the diagnostic test. Now, what are the otics anti-infective that we already discussed in otitis? We used a combination of an antibiotic with hydrocortisone, and also we could use acid or alcohol drops. And you have to be very cautious not to do this if the patient has a perforating tympanic membrane, or if already has the otitis media diagnosed. For acute otitis externa, we already discussed the treatment, so we're going to jump this. Malignant otitis external is very rare. It's mostly in patients that are immunocompromised. It's basically due to Pseudomonas aeruginosa. It could cause osteomyelitis, and even up to meningitis if disrupt the base of the skull and penetrates the meninges. The treatment is basically parental antibiotics and aminoglycosides or carbenicillin, plus of course surgical debridement if it produces osteomyelitis. So it's exactly the same treatment as otitis external, but now you have to use parenteral or IV antibiotic instead of topical. So how do you prevent swimmer ear? You basically could instill alcohol drop or 1 to 2 drops into the ear canal to dry the ear after swimming. A combination of 1:1 isopropyl alcohol and white vinegar may also be used. Topical anesthetics are used in the ear to treat pain for otitis media or external. You could also use dantaparine or benzocaine 3 to 4 times daily, or up to once every 1 to 2 hours as needed for pain. Now, for wax removal and before eye wash, you could use Debrox or dense ear wax or Murex ear wax removal. Basically, what does is soften and emulsifies the wax. So basically, instill 1 to 5 drops depending on the size of the ear canal twice daily, up to 4 days, and then you could go for ear watch or lavage. Now we're finishing here, and we're going to do a third PowerPoint for tuberculosis and video.